Welcome back to another episode of the Pharmacist Diaries podcast. Today I am bringing you a series of videos all week, and this is for World Antimicrobial Resistance Awareness Week. I'm really excited to share real stories behind individuals who are tackling this on a global scale, from pharmacists to doctors, a microbiology registrar, and I found a patient to share her story. Today I am having an episode with Frances Garraghan. She is a pharmacist by background and she is working at Manchester NHS Trust as a consultant pharmacist in antimicrobial resistance. And she is the technical lead for antimicrobial resistance with the Commonwealth Pharmacists Association. She's really passionate about this topic, and I am so pleased that she has taken the time to record this episode with me and to teach you a little bit more information about the topic. Hey Fran, how are you?
Hello, I'm fabulous, thank you. Thank you for having me today.
Absolutely. I'm so glad that we can record this episode and to kickstart this series with your story and your journey as a pharmacist. So tell us why you became a pharmacist in the first place.
I'll be honest, I fell into pharmacy because I wasn't really sure at the age of 16 what to do. I really loved biology. I loved sort of the theory around sort of healthcare and really knew that that was the sort of area I wanted to go to. But I didn't want to be a doctor. I very much wasn't into touching or looking. So, I was at that point thinking, what is it that I should do? Where should I go? And actually one of my cousins the year before had applied to pharmacy. So that got me looking into the degree and thinking, actually, this probably would play to my strengths and my sort of, what I really like to study and the sort of things that I like to study. So that's, like I say, kind of fell into it because I ruled other career choices out in healthcare and thought, actually, pharmacy is probably quite a good fit for me.
Amazing. And what was it like as a university student when you were studying pharmacy? What were your initial thoughts as to what your career pathway would look like, or maybe what was interesting you at that time?
So I really struggled in the first couple of years in pharmacy because I think the degree's changed a lot now. But actually, when we were students, it was very sort of physics and maths the first couple of years, and I didn't do physics and maths A level, so I really, really struggled. And actually, at one point, really considered, is this for me? This isn't what I thought this would be. But by the time I got to sort of third year, I thought, actually, no, this is getting a bit more relevant. I can see why we're doing this now. But at that point, I just very much thought around the different careers, and hospital really called out to me. But because as a student pharmacist, I really hadn't enjoyed the degree, I didn't do any work experience. So I went and did Camp America. So I taught American kids how to, play American football and to swim. So at that point, I was then a little bit stuck for a pre-registration place as it was then, because actually I wasn't a candidate for the bigger hospitals because I hadn't done any of the, pre-work experience that was expected then. So I very much applied to the smaller district generals in Manchester and avoided those, big sort of foundation trust or teaching hospitals as they were then. And found was accepted into a pre-reg place at quite a small district general, but it was actually the birthplace of the NHS. So Trafford General Hospital was where I trained, but it was great because it was a proper district general at that point. It had everything, it covered all the district general specialities and just really gave me that really good foundation to actually hospital pharmacy is where I want to stay.
Awesome. And you obviously started your journey in a hospital setting like I did. And during that time, most likely you would have rotated to all the different areas that, the district general had to offer. And you must have learnt about all the different aspects of multidisciplinary working. Maybe it might have been slightly different to where we are now, but you will have definitely learnt what options are available for pharmacists. So tell us a little bit about your journey into loving infectious diseases, antimicrobial resistance. Did that start as early as your training year, or did you find that later on in your journey?
No, so you're going to very much find through conversations with me that I fell into things and things just happened. So I started in my sort of specialist roles in surgery. I really enjoyed surgery. It seemed quite straightforward. There was an end to, a patient's journey. So I got a specialist job at doing, it was at that point gynae with surgery. And then through that, I developed so the sort of first service to gynae and obstetrics within the hospital that I work in. And I spent a couple of years doing that. And at the time, I sort of did a little bit, dabble in antimicrobials a little bit, because one of my really good friends was the antimicrobial pharmacist. So actually, I got to know it by that through that route. And then unfortunately, something happened on a personal level to me that really changed. Actually, I saw that obs and gynae was not where I wanted to be. So I was unfortunate to lose a baby at 22 weeks in the hospital that I worked in. And I can speak about it now because it's coming up to sort of 13 years that it happened. But the thought of having to then relive that every day in the sort of place and the wards that I worked on was just something that I couldn't carry on with. And again, very timely, an 8A position in antimicrobials came up in the same hospital. And because I had some experience, I realised actually that's where I need to be now. And I can still work in the hospital where it's happened to me, but it was too raw to sort of work every day on the obstetric wards. So like I say, it kind of just happened by chance, and, I haven't looked back since.
Of course, I'm really sorry that you had to go through that experience, but sometimes I guess the most challenging or difficult experiences help to mold us and make choices that are right for us in that moment. And you never know, they're not expected, obviously, but they can have an impact. A similar example with my career journey and being in pediatrics. I mean, becoming a parent has shifted the way that I treat pediatric patients, the way I can communicate with other mums and dads who are on the ward, because you've been through similar experiences with young children, especially when parents come into hospital and they've got multiple children. So they've got one sick child with you, as well as logistics to manage in the home setting. So it's obviously nice to have that connection with them. And I chose palliative care as my area of expertise and something that I really, really love. But of course, those families go through the most difficult experiences. But from a healthcare point of view, the reason why I love it so much is that we can make such a great impact during the hardest journey for them. And knowing that I've got some knowledge and experience and expertise in the medicines around that and helping that patient through that journey and helping the family is something that's really impacted my career journey. And I can't see myself anywhere else now except peds. Like, I really have fallen in love with something, and it took me over 10 years to find that love, but I don't think there's any way that I can turn back from that now.
And I think it's having that empathy, isn't it? That actually, as a junior pharmacist, you maybe don't, because we didn't have that life experience. And now actually it's remembering the people that we come into contact with. That's a massive part of their day and their week. Whereas actually, if we're busy at work, actually to us, they shouldn't be insignificant, because what our interaction with that person actually is a real impact on their whole day and their week. So we need to treat people with the empathy and respect that we want to be treated with. I think it's really good to have that grounding and to remember actually being a patient is really eye-opening, and being a parent of a patient, again, how do you want to be treated, and how should we respect and just be kind to people?
Yeah, definitely. With your role starting in antimicrobials as an 8A pharmacist, so at this point you are quite senior, you're specialist. We have podcast viewers and listeners from all over the globe, so sometimes I have to explain things that are outside of the NHS, but you are obviously an experienced pharmacist at this point. What was the day in the life like for you back then? And then let's try and dive into how that's changed or shifted, and how your role has molded through time.
Yeah, so I actually, at the time, although it was an 8A role, my friend who was in the 8B, so the kind of leadership role, had 3 babies. So I covered her 3 maternity leaves. So I didn't really do the 8A role, because I then cross-covered in between my maternity. So I had 2 maternity leaves as well, and we sort of both covered the same 8B role. So quite early on, I was quite clinical, but also doing that guideline development, that sort of management. And actually, antimicrobials is a great area because you have access to all the patients. So you have, although you specialised in infection, you treat people from, sort of pre-birth and neonates up to, sort of 90 plus patients. So that age and that speciality, you are kind of a generalist because you have to be a generalist. So clinically, it was great because we got to walk around the hospital. We got to, walk the wards of people who needed us. So there were multidisciplinary ward rounds. We worked really closely with microbiologists, and we would be out there each day, but also then sort of fielding clinical queries as well from the different areas. And Manchester, unfortunately, when I sort of was started in this role, we had real issues with antimicrobial resistance. We were probably the worst in the country for it. And although that was a real, if you're at a conference and they say, is anyone here from Manchester? And they all have a little chuckle because Manchester's such a terrible place for this. Actually, it really made me and our service and our people I work with really work hard to improve things and do the best, and to figure out how we were treating our patients, and collaborate with our infection control and again that senior leadership team that we were exposed to very early on. I would say in my career, I was having to go to these senior meetings and sort of liaise with people at that level, which would terrify other sort of 8A pharmacists. But because of that, I then, I was doing audits and QI projects. I was guideline development. Very, it covered each area. So as an 8A in antimicrobials, actually you get a lot more exposure to those sort of leadership bits that actually made me think, I like the ward bit, I like the patient bit, but I also like the other bits, and the sort of challenges and the other leadership elements there. So it was very broad and very, no day was ever the same, no query was ever the same. And when on a Friday afternoon you're asked how to treat a neonate, it was always Friday afternoon. It always is in pharmacy, isn't it? What do I do on Friday afternoon?
Get ready for the calls.
Exactly. So yeah, never a dull day, and that never has been since.
Awesome. And what was it about the hospital or the area, do you think, that was causing increased resistance patterns, or maybe was it a lack of education amongst the public around antibiotic use that made it such a problem for Manchester? So quite a complex question, really. So we were quite a new hospital building, but there were some elements in terms of infection control and the way the hospital was built that contributed to this. There were other bits around sort of education of staff, but there was also around that we started screening, and when you start screening for things, you find it. Whereas if other hospitals aren't screening patients for it, they're not finding it. But Manchester as a whole is got a really diverse population, but unfortunately, health inequalities are quite a big topic in Manchester because of that diverse patient population. And, the sort of English speaking and the ability for us to be able to communicate some of the issues with AMR with patients. And AMR is a really complex issue to try and communicate with patients who we're already having sort of challenges communicating with. So, and this is a big problem with AMR, because it's so complicated. How do you simplify it? And how do you simplify it to people who actually don't engage in healthcare, or, maybe don't trust healthcare? So very, very complex situation, but we're doing a lot in Manchester, and we have done a lot to really try and get to the bottom of it, really. Awesome. So it's good because you like service improvement. You obviously started out earlier on in your journey looking at service improvement for obs and gynae and setting things up. So I guess that will have kind of transferred in terms of your skill set and your experience, which is good. And with this topic, obviously, there's always change. There's always things that can be implemented, guidelines that can be updated, evidence that comes out on a national, if not a global scale that we can use as part of our services in the NHS. What I love about this type of role, and similar to pediatric palliative care, is that, like you said, your patients can be anywhere in the hospital. So you're not necessarily always allocated to a specific ward area where you're targeting just infectious diseases. When I worked in Oxford, they had a full-on infectious diseases unit, which I got to rotate through, which is amazing. But obviously, not every hospital has that access to that type of care or those types of conditions. But I love that you can go to different areas for support for complex cases, and you're basically called in for that kind of help, or they've tried multiple things that haven't necessarily worked and they need microbiology as well as pharmacists to try and support them to improve the options for the patients. Or there's a lot of resistance patterns where we're looking at different things that we can do. And as a pharmacist, that is one thing that really makes me love my job, rather than just being allocated to a ward with kind of 40, 50 patients. And I've learned that I like this idea of kind of chopping in and out where necessary and providing that more like specialist care. And for those who don't know, I'm currently locuming at Stoke Mandeville Hospital. I'm working with Claire Brandish, who's their lead kind of antimicrobial pharmacist. And every day we go to different ward rounds or multidisciplinary team meetings, and we talk about a variety of patients who are on antibiotics. And it's been such an enjoyable experience working as part of a multidisciplinary team with doctors, microbiologists, and pharmacy, and as well as nurses as well. When we do OPAT prescriptions and we send patients home on IV antibiotics, it's been really interesting to learn their perspective of administration, kind of how patients are going to get access to the medications if they're on an antibiotic for 3 months or 6 months. We go to trauma and orthopedic ward rounds, the spinal ward round, and then mainly on a daily basis, we go to ICU. And I've been loving it. I really love that I'm not in one place on like from 9 till 1, on a ward. That I don't know what it is about being trapped in one location, but I get to move around, which makes me really, really happy. But also you can chop in and out of doing other things. You've got that time and the variety in your schedule to sit down and have a meeting, or update a guideline, or look at something related to formulary, or fill out blue tech forms, and then go and see a patient or a ward round. And that really has kept things interesting for me. So if anyone who's watching this video or listening to this podcast episode, if you're considering a role in infectious diseases or in, antimicrobials, this could be an opportunity that could provide that variety if that's something that you're looking for. And on a national scale, there's loads of fun meetings to attend, things that you can get involved with. And even at your hospital, you're probably most likely linking with GP practices or community pharmacies as well to see how we can improve antimicrobial resistance as well. So from the point of view of working as a lead pharmacist, tell me how you kind of got involved in more of the national projects, or where you started your journey with the Commonwealth Pharmacists Association.
So the Commonwealth Pharmacists Association, we're running the first round of their Commonwealth Partnerships for Antimicrobial Stewardship. And it was at a time when in our hospital we were going through yet another merger, and things were challenging and things were really difficult. And again, it's one of those times in your career where you think, am I doing the right thing? Do I still want to work in the NHS? And really, makes you think actually, how long will I stay? So it, like I say, it was a challenging time. And this randomly, the Commonwealth pharmacists were holding a meeting in our hospital to launch this programme. So I went along thinking, I think I need to know what that's about. Not having done any global health work before, not having travelled anywhere off the beaten path. The furthest I'd travelled was kind of Australia and America, and very much within a comfort zone. And so I went to this meeting, and there was a couple of people that I knew there. And there was Sarah Kavanagh, who works for CPA, who was really like, right, you guys need to get together and you need to put in a grant for this project. And as a hospital, we had a partnership with a hospital in northern Uganda, so Gulu. So I thought, well, why not? Let's do it. And one of my very good friends, Stephen Doherty, was on the project as well. Stephen was a lot better travelled than me, so I thought, well, if Stephen can do it, at least I can sort of be his little. I've never been to Africa before. This, Stephen can be my support. And we had a health psychologist, Eleanor, as well, who was on the project, who was, again, amazing, because having never worked with a health psychologist before really made us think about how do we train, how do we change people's behaviour through the training that we do, rather than just providing some training. So I travelled to Uganda twice, and very much a culture shock the first time I went. And, made us realise actually the expectations we'd put on the deliverables of this project were too high. Because having never been to a hospital before, to try and link with them virtually to say this is what project we've come up with together, actually when you get there on the ground, things are very different. And, there's different challenges, and antimicrobials, the challenges of using antimicrobials are very similar, but hospital structures are very different. And I remember coming back from the hospital on the first day and just cried. And I just said to Stephen, I don't think I can do this. I am so out of my comfort zone that I just really can't cope. And Stephen very much was like, now, come on, let's take this step by step. And again, Eleanor as well, I think they just had to talk me down. But I'm so glad they did, because actually then when you then think again and think, right, where are we? What are we trying to achieve here? How can we work together with our colleagues and Zainab, the pharmacist in Gulu, and how can we make this work? So after that, I did a global health, the Chief Pharmaceutical Officer's Global Health Fellowship, which was very much combined leadership, and again, a bit more around the global health and a bit more around sort of structures in different countries and why things are the way they are. And it gave me a lot more grounding, a lot more understanding of the project and what we could deliver and how that would influence sort of national, international policy. And then a sort of very part-time opportunity came up with the Commonwealth Pharmacists. And I thought, well, I've got a Monday off. I was a mum of two young children at that point. I thought, oh, this sounds interesting. I've got some free time on a Monday. You never have free time as a parent, do you? But yeah, I figured that's fine, I'll do that. And it started as maybe a couple of hours a week and has now gone into sort of 10 to 12 hours per week, as well as a sort of 4-day a week role in the NHS. And, I love it. It's very much what's kept me in my NHS role, because it gave me a different focus. It gave me a different perspective of why we are doing what we are in terms of antibiotics, and also gave me a bit of actually, we've got it a lot better than other people do. So why are we moaning? So yeah, it gave me a grounding and a sort of better understanding of why we should do things, and why in Manchester we can't just solve some problems in Manchester without thinking about the wider sort of global health benefit, really. And yeah, haven't looked back. Amazing organisation to work for.
Yeah, no, I completely agree. And I have interviewed Sarah Kavanagh and Victoria Rutter on the podcast. Claire Brandish has been on in the past. I can link all of these episodes in the show notes, because they're really awesome episodes if you're looking to learn more about global health or opportunities to work abroad as a pharmacist. My question about your actual trip abroad for this partnership is, what was the actual project about? What were you aiming to achieve? And like you said, that what you actually found on the ground when you got there was very different in terms of the expectations as to what you could deliver. Can you dive into a little bit more detail on that?
Yeah, so it was very broad what you could look at. And it was very important that it was a UK with an African country partnership, so that you could very much sort of share UK experience, but also the importance of bidirectional learning. So it was very important to think how have I developed and what have I brought back to the NHS through working in that project, which is massive and with massive amounts of knowledge and understanding. But so one of the main goals was to really look at the use of antimicrobials in the prescribing. So we did 2-point prevalence surveys at the Gulu Hospital, sort of initially led a little bit more by us, and then the second one very much led by the team in Gulu, sort of upskilling. And this was a point prevalence as a snapshot of who's prescribed antibiotics in the hospital on this day or, across this week. And then through that, we identified areas of further focus and sort of understanding, maybe you should look at pneumonia because you have high prescribing and high rates of pneumonia. So maybe that's an area to sort of do some quality improvement. And then we held this on our second visit. We overlapped 2 teams over 3 weeks, and we held this 3-week training camp. So we trained people every day, different cohorts every day. And in the end, we'd trained over 200 people in these hospitals, 200 different healthcare workers in the basics of AMR and AMS. And they'd all pledged to become antibiotic guardians. So again, if you just to sort of flag that really to your listeners in terms of antibiotic guardians, and if that's the only thing you do this week, then pledge to be an antibiotic guardian, because that campaign is really useful for these sorts of events and these sorts of learning to at the end say, right, how are we all going to do this? What's our final pledge at the end of this training? And Diane Ashiro Oridopi was a really fundamental person in that campaign, but also fundamental to the establishment of the CW PAMS programme, and was my kind of mentor at the CPA, and again is one of the people who's really influenced my career. So thank you, Diane, if you're listening.
I'm sure she will be. I know she's a big advocate for these types of podcasts or people sharing their stories, because at the end of the day, we're putting out all this information online, which can be accessed from anyone all over the globe. And I'm really fortunate to actually have this series. For me, it's really nice that I get to showcase pharmacists, of course, put them in the limelight and showcase our profession. But for something that I'm working on at the moment as a pharmacist in my locum role, it's really nice that I can use this platform to share different experiences around the globe. There's over 125 countries now tuning in, so I'm looking forward to seeing what type of feedback we get, what type of information comes across from this podcast series. And when you got back from Uganda, what were you thinking in terms of things that you could personally implement into your hospital setting from, experiences that you learned from that trip?
Some of it was almost not trying to do too much. And, AMS is such a big area. So actually what Uganda taught me, and what's still working with the different Commonwealth countries in Africa has taught me, is actually don't try to do too much. Why don't we focus on one area and we will really, make this a big highlight. And so we all know what we're focusing on. Also, as I said before, it was the first time I've been able to sort of understand a little bit about behaviour change. I'd never really thought about it before. I think as pharmacists, we sometimes are guilty of judging that, people have purposefully done a prescription the wrong way because they didn't follow the guidelines. Where actually what working on sort of behaviour change in Uganda allowed me to understand is actually there's different reasons that people make decisions and different influences on behaviour. So the COM-B framework, so capability, opportunity and motivation, are all sort of things that impact on a reason that people make choices or people do certain things. So how can we look at those when we're talking to people and not just assume people are making a decision because it's the wrong one, but actually why did they make that decision in the first place? And rather than judging, trying to understand it with the person is so much better, and getting them on board that way than really saying, well, these people just do things wrong because that's what they choose to do. And yeah, as pharmacists, we do judge a little bit too much. So it's made me judge a little bit less and talk to people and understand more.
That's so important. And I've been thinking about this a little bit more as I teach pharmacy students, because we always talked about shared care decision making with our patients. And we do talk about this all the time to pharmacy students who are currently going through the undergraduate degree. And when I was taught pharmacy, and it wasn't even that long ago, 14 years, I've been qualified, it was more a case of being able to communicate the right information to a patient and be able to relay fact about the medication, the indication, the dosages, maybe some side effects, interactions. So you're giving them information about the medication that we're expecting them to take, but we don't necessarily have the knowledge, the skill, the experience at that level when you're studying pharmacy to help provide the right information to the patient and then allow them to make the right decision for themselves, or giving them multiple options as to what may or may not work for them, and then allowing them to make the decision as to whether A, they even take the treatment, and also how they take it or for how long that they take it, and having a negotiation. But obviously this is something that we need to focus on because we want to be able to give patients a choice. And I love that you found interest in something different, especially with behavior change. You can apply that to any of your patients now across the hospital when you're in a clinical setting. And it's probably provided you with so much kind of knowledge and skill to do something different when you're having that consultation with a patient when they're faced with quite maybe a multi-drug resistant infection where we're limited with choice, or horrible side effects like with ciprofloxacin, and lots of risks and things that come up with medications that we're using to treat infections. Have you got any kind of feedback on that and how it's changed your practice?
Again, it's the ability to listen and to ask questions and to be inquisitive rather than deciding you know what the answer is and why somebody does something. Because actually, once you start asking, you uncover things that you never really factored into why you think. So I think, refraining from making assumptions about people and really, engaging with patients. And, it's so important, that patient communication. And like you said, ensuring that pharmacy students and our trainee pharmacists and those junior pharmacists can actually talk to people and, not just assume they know why something's happened. So what we've done in Manchester is we developed some, we called it an AMS change training. So with 2 professors of health psychology in the University of Manchester, we got together and we've designed this training because it just really blew my mind that I'd had to go to Uganda to work with people who worked at the University of Manchester down the road. So we were like, right, this is a problem in Manchester. And we've sort of equipped pharmacists and different healthcare professionals with some of that skills around behaviour change conversations and how do you have that conversation. Because people think it's too big and they think, oh, behaviour change is scary. Whereas actually giving them some general sort of skills to be able to, like you say, influence conversations with patients, potentially influence conversations with family and children at home, quite a useful technique in all elements of healthcare and, your own personal life, to be able to talk to people in a way that you're not telling them or making assumptions, but actually you're engaging them and bringing them along with you is an important skill to have.
Yeah, absolutely. And I love that you also bring up simplicity in this conversation in general, because I've worked abroad as well, working in Abu Dhabi as a pharmacist, and I really struggled to gain access to medications from an import perspective. The role that I was in, we built a pharmacy and we had to import medications from all over the world for ambulances. And things like adrenaline EpiPens would take 9 months to get into the country. And it really gave me a true appreciation for the NHS at that time. And this is now, I moved there nearly 10 years ago. So obviously things will have changed by now. But when I moved there, I just finished my residency in Oxford as a junior band 6 pharmacist. And back then there weren't that many problems with accessing medications. There weren't that many issues with supply. We were a big teaching hospital, so we were really fortunate to have access to most medications on their formulary as well. I didn't have that many experiences with struggling to get medications. But now when we look at the NHS, things have significantly changed. And now working in pediatrics, it's even worse because we're constantly like looking for sources of unlicensed liquids or trying to import medications, or can we crush tablets? I mean, the list of issues is kind of endless right now. But when I lived abroad, I had such an amazing appreciation for the NHS, and I actually couldn't wait to go back and work for the NHS because I missed it so much, because life was just so much easier than what I was dealing with abroad, and understanding the complexities of all the medical imports and the supply chain procurement. It was so different to what I was used to. And my parents are both from Kenya and Uganda. I've been there so many times, to Tanzania as well. So I have had exposure to what life is like there, the challenges around healthcare access, medications being difficult to get hold of, people not being able to afford the medications. Maybe their healthcare clinic is miles and miles and miles away and they have no transport to get there. So all of these factors also help me to appreciate the bigger picture. And I'm so glad that you had that opportunity to obviously travel out to Uganda and see things from a different perspective, from a healthcare point of view. But I wonder if you noticed, working there even for a short period of time, like how happy their staff are and how grateful they are for what they've got, and how they still come to work even though life is so challenging in comparison to what we deal with a massive smile on their face. And they just like crack on with the job, and they're really, really happy, kind, caring humans, which is really different to sometimes what we experience in the NHS. Not that we don't love our patients and our jobs, we do. But at the same time, we just forget how to be grateful for what we do have, because we don't necessarily see what other countries are facing.
I totally agree. And I think you've been so lucky in your career to have exposure to that actually makes you appreciate the NHS, because, you know, there's so much negativity around the NHS. And actually, you know, we are all doing our best with limited resources now. And actually, you know, it is now a sort of limited resource setting, not like, you know, compared to our colleagues in Africa and other countries, but actually working with our colleagues in Africa really allows us to understand actually how do you do these things when you don't have access to all the medicines that you know think you should have, or, you know, with limited sort of capacity within hospitals. And I think that's again where that bidirectional learning back to the NHS is really useful, because you can see a different perspective and you can sort of see that you don't need a pot of money to do everything, you know, thinking frugally, you know, innovations that come from that sort of frugal innovation. It's so important to look outside the box and think, actually, what are we trying to achieve and how can we achieve it with what we have? Because there's not a pot of gold at the end of the rainbow. You know, we are all struggling in our departments, in our hospitals, to do things with the resources we have and to do the best for our patients. So I think, you know, definitely our colleagues have really opened our eyes to how can we do things, and as you said, how can we do things positively, and how can we be nice to each other is, you know, one of the fundamentals of how I work, really. If you can't do anything, just be nice.
Yeah, agreed. But I know, and it is hard. Like what we're going through right now in the NHS is tough. We've got mass amounts of stress and burnout and lack of resource. We don't have enough funding when we know we need funding, whether it's for individuals who are working within the hospital, whether it's resources for patient care. I mean, the struggle is real, right, for us. But sometimes you get a shift in perspective when you see other things around the globe. Can you tell us a little bit about your actual role as technical lead for antimicrobial resistance with CPA? What is the goal of that role, and kind of what skills are you using that are different to what you use in the NHS?
Yeah, so as I said, I kind of, again, got into that role by chance, but we have two antimicrobial resistance work streams. One that we do with the Tropical Health Education Trust, who have just changed their name, I think Global Health Partnerships they might be now. And that's our CW PAMS programme. That's a partnership, a health partnership model. And that's now across 8 African countries. And then we have our Spark programme, which is very much focused around supporting 5 countries around sort of access to guidelines. So we have a prescribing companion app that's been developed through that. And then also our data for action work stream. So supporting people to do point prevalence surveys, but also to look at that data and to do interventions. So not just to sit on it, an audit, to actually look at that and say, how can we make an intervention that's going to change practice or going to change how we use antimicrobials? So 2 similar but very different programmes that are funded by the UK Fleming Fund. So very fortunate to have the UK Fleming Fund on board and supporting those two projects. So my job is very varied. So again, never a dull day. I work very closely with our programme managers and our head of programmes, but also our education team in the CPA to support our programmes and our individual projects in terms of technical access to technical resources, or how do we think this is going to work. But also we're very fortunate to have a team of technical in-country consultants in our countries that we work with. And these are the people on the ground who know what's going on. So we've done a lot of work to try and sort of upskill our team and really ensure that they've got the confidence and knowledge to support our in-country partnerships as well. So I sort of support that team, but also, that team has become amazing and they're the people who know exactly what's going on. So actually we've been able to step back a little bit, because from a sustainability point of view, the individual projects, but the individual teams in our countries have learnt so much and have developed so much. And that sort of knowledge of AMR and AMS within their context, they are now the experts. So our support in a technical capacity changes slightly. And then we've also developed Chico, who's one of our team members in the CPA, has developed this African Leadership Fellowship. So in our CWPAMS project, we've developed this cohort of pharmacists who are now have gone through leadership training. They've done sort of smaller projects within their healthcare partnerships to really focus around strengthening their capacity and resilience and making those leaders in AMS within our 8 African CWPAMS countries. And they are amazing people. And it's so great to see the journey they've been on. And, through mentorship and different aspects of leadership training has really transformed how they work, but also from a sustainability point of view within each country now. You've got a cohort of pharmacists who are leaders in AMS and are driving everything forward. So unfortunately, I'm about to leave the CPA for a different role, but actually I feel it's the right time to leave the CPA because there's different projects that they can then move on and work on. And I've really almost seen projects through, and I'm at a happy point where I think, right, this is time to go, because actually it's all worked great and now you don't need me. You've got these other people who can do this.
I love that. And that's really exciting. And I will put all of the links to the CPA website in the show notes for this episode. And I just think for those of you who are listening or watching this video, if you are interested in these types of partnerships with Commonwealth countries, get on the website. I believe that we are close to, is it round 3 for the partnerships?
Yes.
So that will be released sometime soon. If I gather that information, it'll be in the show notes if I get access to it. But definitely get onto their website because they advertise everything through there. And I mean, I remember when the first partnership was kind of advertised, and it's growing. Like, this whole Africa Leadership Partnership is just so awesome. And I'm so glad that, it's evolving and changing and molding to what people need and what's required on a global scale. And so many people are getting involved, which is so exciting. And working with Claire has obviously been really nice for me because they have a partnership in Uganda, and it's so nice to be part of the meetings every month just to see how things are going and be able to be part of that journey for them. Thank you so much for your time today, for sharing your journey, for giving us insight into why you love your job and what you do. I hope that this video is going to provide a lot of information around antimicrobial resistance, and this whole series is going to be beneficial for people. But thank you again for volunteering your time for me.
Oh, no, thank you so much for having me along. Again, it's reflection time, I think, and, getting to know your career journey as well is so interesting. Thank you so much.